Hello, everyone, and a warm welcome to today's highly anticipated event. I'm Dr. Nigar, your host for the day, and I feel truly honored to introduce our distinguished speakers. Firstly, we have the renowned endocrinologist from Trivandrum, Dr. Jothydev Kesawadev. He is the chairman and managing director of Jothydev Diabetes and Research Center, Trivandrum, and holds the esteemed position of president at DTech India. Next, on our panel, we're privileged to have Dr. Manoj Chawla, a highly esteemed diabetologist. He is the director and consultant diabetologist at Lina Diabetes Care and Mumbai Diabetes Research Center in Mumbai. Dr. Chawla also serves as the scientific co-chair of DTech India. Our event today will be expertly moderated by Dr. Mithun Bhartia, a diabetologist and joint organizing secretary of DTech India. Now, without further delay, I would like to hand over the stage to Dr. Bhartia to guide us through what promises to be an enlightening and insightful session. Dr. Bhartia, over to you.
So, thank you, Nigar. Thank you, MedSynapse, for this meeting. Sometimes the essence of the meeting is very good when you're doing it with your friends. Then, the flavor of the meeting is very nice. And, we can have no bars, no political, straight off the hook question and answer. And it's my pleasure that I've got two very close friends, two very eloquent speakers with me. And I think we're going to talk about CGMS and pump. And I think, pumps have changed and they are going to change the way type 1 diabetes live. And things are getting better and better. And we've got no better person to discuss that than Dr. Jothydev Kesawadev, who's going to talk about the evolution of insulin delivery through diabetes technology. So evolution of diabetes technology and insulin delivery. And I request my dear friend, Dr. Jothydev, what we will do is once Dr. Jothydev has spoken, then we'll ask Manoj, and then we'll do question and answers together. So over to you, Jyoti.
Thank you. Thank you, Dr. Mithun, and thanks, Dr. Nigar. And I am also equally delighted to be amongst my friends, Dr. Mithun and Dr. Manoj Chawla. And my duty is to have an introduction. This is going to be a series from Diabetes Technology Society of India and our DTech, the Diabetes Technology Trust of India, and we are planning for a series of webinars. And tonight we will be discussing two topics, and I am going to start with insulin delivery. So I'll be going through the history, evolution, and the future. So let me start sharing the slides. Just a moment. So many windows are open here. Okay, fine. So this is going to be a 20 to 25 minutes brief lecture on the evolution of diabetes technology focusing on insulin delivery. And these are my disclosures, but I don't have anything to disclose pertaining to this lecture. And this is how we are going to proceed in three different sections. And the first one is from the discovery of insulin until 2000. And then we will consider the history up to 2024, and then beyond 2024, we'll be definitely discussing in the upcoming webinars. And this is a review which I would like to have as an introductory slide. And this has been published in Diabetes Therapy in 2020. Evolution of insulin delivery devices from syringes, pens, and pumps to do-it-yourself artificial pancreas. And this has been an extensive review. And this has been cited by many, including the international scientific organizations. And I will be briefly touching upon all those milestone innovations. Let me start with insulin syringe. Remember, insulin was commercially available in 1922. And the first insulin syringe kit, yes, it was available as a kit in 1923. And it was BD who manufactured and launched the first syringe made exclusively for insulin injections. And they are still the leaders for insulin injectables. And I'm jumping over to the insulin pumps. And this is in 1963. So the prototype of insulin pumps were actually displayed by Arnold Kadish in the year 1963. And insulin pumps are not new. So whenever we discuss about insulin pumps, or whenever we have programs related to workshops or training programs on insulin pumps, more than 90% of the doctors have a feeling that this is something very new. No, it is not. It is not a new innovation. It has been available since 1979. And the documented one is from 1983 onwards from Minimed family. And I would like to say that insulin pumps have become extremely popular after the publication of DCCD, since more than 40% of patients in the intensive arm were on insulin pump therapy. And this led on to the wide popularity of the use of insulin pumps in type 1 and probably in other types of difficult to treat diabetes. So remember, insulin pen was launched by Novo Nordisk, and that was only in 1985. And this is years after the launch of insulin pumps commercially. But ever since insulin was discovered, there used to be a concern, and this appeared even in the newspaper. And in the newspaper in 1920s, one newspaper wrote, there is an innovation now, and that is an extract from the animal pancreas. And it is a very potent insulin which can reduce the glucose, but the most important side effect is a life-threatening low glucose. And this fear is there with every person and with every doctor treating diabetes, hypoglycemia due to insulin. And hence the dream of automating the delivery of insulin. And I would like to have the 4 dreams. And are they getting fulfilled or not? You have to decide at the end of my lecture. Number 1 dream is the dosing of insulin to be automatic, sensing to be automated and more reliable, preventing both high and low, and the dream of a faster acting insulin. Some of them are already available commercially. The 1974 discovery of biostat by Dr. Ernst Friedrich Fieser. And at those times, this was thought to be the closed loop system. And believe me, it definitely worked. It certainly worked. And there are more than 200 publications related to the use of a biostat, both for glucagon and for insulin. But as you can see in the picture, it couldn't be replicated in the free living environment. The patients need to be hospitalized. And the history of intraperitoneal insulin pumps, Roche and Medtronic used to have these intraperitoneal insulin pumps, and there are a lot of clinical trials related to this with the highly concentrated insulin, but all of them were discontinued due to the multiple challenges, including the occurrence of infections and septicemia. And there are still a half a dozen patients globally using these systems. And this is particularly useful in very, very difficult to treat diabetes. And what happened to inhaled insulins? The inhaled delivery of insulin, all of you are aware. Exubera from Pfizer withdrawn within a year. And we were also in our hospital part of some of these clinical trials from Novo Nordisk. All of them were discontinued. The only one inhaled insulin which is still surviving is Afrezza from Mankind. And it is used as a rapid-acting insulin and is available in multiple dosages. And there is still a concern about the use of inhaled insulins, and I would admit that these are not popular delivery devices. And now, let me move on to the history and evolution of insulin pumps, because the topic today is on delivery devices, and this is in India when we officially launched insulin pumps way back in 2004. And in a couple of years, in 2009, we started publishing, and this is in Diabetes Technology and Therapeutics, on the multitude of benefits offered by reducing or minimizing the glucose variability, improving the sexual dysfunction, reducing the total daily dose of insulin, dramatic improvements in the pain of peripheral neuropathy, and still the body weight maintained or resulting in a reduced body weight instead of increase in the body weight when you are carefully titrated dosages of both basal and bolus. And this is with the use of insulin pumps and the suggested guidelines based on experience and cultural differences. And this is published in the year 2010. And some of the doctors, especially the senior doctors, will remember this. And for us, it was actually an urgent necessity at those times. Since we were using insulin pumps in India, and no doctors were aware of these technologies. And we were using in type 1, we were more using in type 2 diabetes, since at those times GLP was not available, gliflozins was not available, and more than 20 to 30% of type 2 diabetes, it was not even amenable to a basal bolus therapy. And hence the insulin pumps and the continuous subcutaneous insulin delivery resulted in much better outcomes in type 2 diabetes as well. And from a legal point of view, it was a necessity to have the Indianized guidelines. In 2006, we started having our patients coming from many countries, including the Middle East, with the new sensor augmented pump. Look at the size of the transmitter, huge size along with the sensor. And that was the beginning of continuous glucose sensing along with an insulin pump. And this was in 2007 when we started using the sensors along with the pumps in India. And this is the patient from India. You can see that the size of the sensor has shrunken and it is very small in size. And remember, the sensor augmented pumps are not automated, but they were still capable of displaying the sensor values, which used to change once in every 15 minutes. And also alerts before at the time of hypo or hyperglycemia. And it was in 2012, I still remember the first patient on VO insulin pump. He was a doctor from another state in India. And that is the threshold suspend. So that was the first insulin pump along with the sensor. You can see the sensor over there, where when there is a hypo, you can decide on a threshold, the insulin delivery gets suspended. And let me briefly go through the journey from standalone insulin pumps to the artificial pancreas. The new terminology for artificial pancreas is AID, or automated insulin delivery. And this has been the question, when will it happen? And this has been the question the doctors are confronting from their patients for, I would say, more than 100 years, ever since the discovery of insulin. And the solution is closing the loop. And we are very close to closing the loop. And for the students and for the junior doctors, or for the academic enthusiasts attending the conference, this is how it has evolved. The first gen, you have 1, 2, 3 stages. The second gen, you have 4th and the 5th stage. And the final stage will be the 6th stage, representing the 3rd generation of artificial pancreas, or DIY, or the automated insulin delivery devices. There are 3 popular AHCL. So AHCL is the stage 4 of automation. That is advanced hybrid closed loop system. In stage 1, you have seen it is a threshold suspend. It stops insulin delivery at the time of a hypoglycemia. But in stage 2, it can prevent hypoglycemia to an extent. Both hypo and hyper minimizer in stage 3, where basal is automated. And in advanced hybrid closed loop, you have 3 popular devices now commercially available, of which the patch pumps from Omnipod are very popular. But in India, we have only Minimed 780G, where the algorithm is superior when compared to the patch pump, resulting in a better time within range and a reduced time above range and below range. And these are the 3 popular algorithms: the MPC, which stands for Model Predictive Control; the Proportional Integral Derivative, which is the PID algorithm used in 780G. MPC is used in Omnipod. And then you have the fuzzy logic. And this is especially useful for automating the bolus delivery. And what is 780G? We will be discussing much in detail about the AID in the future programs. But here, as a summary, I would say that 70G automates both basal and bolus delivery once in every 5 minutes. And this is in response to the sensor glucose levels. Metronic sensor will have a sensor value which will change once in every 5 minutes. And once it has reached the maximal basal, and still if the glucose is higher than optimal, then it will deliver a micro auto bolus. And this is how the automation has resulted in an improvement in the TIR. Remember, the minimum which is recommended for the TIR is more than 70% in type 1 and type 2. Minimum is more than 70%. And this has been accomplished with the stage 4 of automation. So it is already there. And all these devices are capable of reaching more than 70% time within range. And this is again a recent real world evidence from our center on 780G. And this is from the 6 months experience in the earlier cohort. Now we have more number of patients. And we have demonstrated more than 80. So you can see that it is 83% time within range. So this is a real world experience which is much better than which has been seen in the clinical trials. And it is 0% time in level 2 hypoglycemia, 0% time below 54. And this is highly acceptable. And level 1 hypoglycemia is just 2%. Less than 4% is the international consensus recommendation. Everybody cannot afford a pump. And everyone requiring a pump probably won't be comfortable having a device attached to the body. So there may be a subgroup, or there may be a couple of people who cannot afford a pump. And for all those subjects, you have the option for a connected pen. Connected pens are not similar to insulin pump therapy, but some of them are really advancing very well. It can be broadly divided into a tracking insulin pen, a smart insulin pen, and smart insulin caps. These are the 3 broad classifications, depending upon the stages of advancement. And what basically, these are the pens with the Bluetooth enabled cap communicating with a continuous glucose sensor. And there is an inbuilt algorithm within the mobile phone for automating or having a person manually administer the bolus. And then they have the near field communication so that the data from the insulin pen can be wirelessly transmitted to a mobile phone and to the glucodiescent as well. And this is on the Novo family, NovoPen 6 for adults and NovoPen Echo Plus. Both of these are connected insulin pens. And Bigfoot, very unique. FDA granted clearance to Bigfoot Unity Diabetes Management System. And this is for people with diabetes using multiple daily injections. And you can see they have the smart pen caps available for both basal, bolus, and for almost all insulins available in the market. The moment you scan your sensor, and this is the Libre sensor over there, the moment you scan the sensor, it will display not only the glucose value, but it will also display the insulin to be injected. It will also display the insulin to be injected, and this comes from the mobile phone dosing algorithm. And let me now have a very brief discussion on do-it-yourself artificial pancreas. People with diabetes, the parents of children with diabetes, they were waiting for more than 90 years after the discovery of insulin. Nothing is happening. Of course, there were insulin pumps, there were sensors, but automation was not possible. And still, many were developing complications, and life with diabetes, especially type 1, is a nightmare, especially for parents. And this is the innovator, this is the creator of DIY artificial pancreas. And this is Diana Lewis, and we met her recently at the ADA in 2023. And if you look at the evolution of DIY, or the open source automated insulin delivery, that is a new terminology, AID, and this is open source AID. They are far ahead of commercially available systems. Even in 2018, they have the RF1, the super micro bolus, and even unannounced meals, which is supposed to be available in this next stage 5 of automation in the commercially available systems. And these group of people, they are very successful in publishing even in top indexed journals such as NEJ. And this is with Dana insulin pump from South Korea with Dexcom G6 sensors, and they have documented much better outcomes. And this is more than 10% improvement in the TIR. And again, if you are interested in learning more about do-it-yourself artificial pancreas, we have another review from our group. And this again is referred to by the ADA, EAST, and so on, where the ADA has categorically made a statement. We cannot make a prescription for open source algorithms or for DIY. But if somebody needs a support and if they are already using it, then you should have the basic know-how, how to support them, how to assist them, because many of these devices are providing with much better TIR. I have been discussing and lecturing on Damiano. This is Damiano and his child with type 1 diabetes, David. And he has been working on an artificial pancreas for more than 10 to 15 years. And now, of late, they are successful. So they are getting recognized. The DIY community is getting recognized. The DTechs are getting recognized. And this is the FDA clearance for the beta bionics islet ACE pump. And ACE pumps can be connected to other dosing algorithms and the other CGM devices, automated controller enabled pumps. That is a full form of ACE pumps. And this FDA clearance came in the 19th of May, 2023. And I had the fortune of meeting Damiano again at the same ADA in the June of 2023. And we are now good friends. And this is his first presentation at the American Diabetes Association. Another successful DTech. And this is Howard, who is the innovator of Tide Pool. And this is the first fully interoperable automated insulin dosing app, which works along with Medtronic, tandem insulin pumps, omnipod insulin pumps, Dexcom, Libre, and so on. This is a picture I took along with Howard. And this was when we visited for the ATT meeting, again in the February of 2023. So in a nutshell, even the DOIE, the do-it-yourself artificial pancreas, and this moment is also, we are not waiting moment, they are also gaining momentum, and they are also getting approved by the authorities. And this is the announcement. All of us are going to make official announcements for the DTech. Dr. Mithun, Dr. Manoj Chawla, and myself, we are all the organizers for this program. And this is going to be in Kerala, in my state. And this is going to be in the beautiful city of Kochi on 17th, 18th, and 19th of May in the very same year, 2024. And let me conclude with this statement. When we were students, we were taught that complications of diabetes is related to the duration of diabetes. But now we know that almost all these complications are preventable complications. Almost all these are preventable and avoidable accidents. We do have the solutions. As modern medicine doctors, as a responsible, duty-bound modern medicine doctors, we have to respect evidence-based publications and suggest to our patients on how they can avoid the accidents. So I stop here and thank you. Thank you very much, my dear friends.
Excellent deliberation, Jyoti. I'll ask Manoj to talk about something which perhaps, we need to sense the sugar to actually do what we are doing. So he's going to talk about evolution of diabetes technology in glucose sensing. And then after that, we shall have a brief discussion among, the slides and if there are any questions from the audience on that. So what to you, Manoj?
Thank you. Thank you, Mithun. And thanks, MedSynapse and Dr. Amit Gupta for bringing this about together as a prelude to, as we move towards DTechCon 2024. Dr. Jothydev gave us the welcome note inviting everyone. So Jyoti did a beautiful presentation on the evolution of insulin delivery. I'm going to move to the other side, which is monitoring, and talk about how evolution of glucose sensing. So let me Okay. I believe I should have the slides there. Okay, so let me move towards taking you through the evolution of glucose sensing, and we'll talk about what's happened and what's available, though the intent is to deep dive into the finer nuances of continuous glucose monitoring and the analytics there into our next webinar, which will be planned soon. This is more of an introduction and history of how things have evolved. Okay, so what is, of course, CGM? We start with the basics. It's a method to track glucose levels through the day and night. CGMs take systems, various different ones, take the measurements at regular intervals. This could be 5 minutes, this could be 15 minutes, and translate those into a complete dynamic data, generating glucose direction and rate of change reports. Of course, the way CGMs today are reported has evolved from earlier ability to see only on the screen to all the software reports which are generated today with a lot of help of AI also coming in. So as seen here, usually will be a transmitter attached to the skin, and there will be a small sensor tip which is going to measure the interstitial fluid glucose. So glucose in the interstitial fluid hits the sensor here, causing a glucose oxidation reaction to occur, which gets measured, and these electric potentials then get transferred into the actual number corresponding to the interstitial fluid glucose. We have different systems available, and I'll take you through the history of some of these as to how they have evolved and what we have available today globally and what we have in India. So if you see the first actual CGM system was by MiniMed, which later on then became Medtronic as a company. This was in the 90s that they came out with this product. And then you can see the whole movement of different efforts, including the initial GlucoWatch biographer, which was by a company in San Diego, California. They came out with their further versions. Then Medtronic evolved its systems towards Guardian and Guardian Real Time. Dexcom coming in with its systems, evolution of Dexcom systems to the current G7 and the Dexcom 1, which they have in some countries. And then, of course, the Abbott systems coming in. The earlier systems by Abbott were called the Navigator, had its own issues. Well, they hit gold when they started the Libre series, which now dominate the CGM system in large parts of the world. And then, of course, the implantable sensors, Eversense, which is by a company called Sensionics. Again, most of the Sensionic individuals were the ones who broke away from MiniMed and Medtronic and started their own company and their own research and development in the glucose sensing area. So here again, we see the earliest CGM in human subjects in 1960s, a huge laboratory effort, large machines, biostators. And then, as I mentioned, the earlier report, the Freestyle Navigator, which was an Abbott product, the Dexcom systems, which evolved to G4, G5, the G6 Pro. Again, now we have moved beyond that to the G7 systems and just the Dexcom 1. And then the MiniMed systems and the Abbott Libre. So it's just a picture of what the evolution for different systems has been. Now, if you look here, there would be certain aspects for us historically to see the evolution. So the Medtronic Gold moved into the Medtronic iPro 2, which was the professional CGM. It did require calibration 3 to 4 times a day. The approval was in 2011. Then, of course, you have had these systems being used in its insulin delivery systems with the insulin pumps, which Jyoti gave us a brief overview into. Dexcom, the Dexcom G4 Platinum moving to G5 and then G6. The major difference there means till G6, even the Dexcom systems required calibration by SMBG to have validated reports. But then the game changer for many of us has been the Abbott Freestyle Libre systems, which came in around 2017 and do not require any calibration. The Sensionics Eversense implantable ones also require calibration 2 times a day at least, which was launched in 2018 in some parts of the world. So we go back to the first system that many of us, including Dr. Jyoti, Mithun, Dr. Banshi, myself, would have used, is this little piece, and I'm sure I still have this in my clinic somewhere, the gold system which we started using, and this would work for 3 days, would have require the patient to do SMBG and calibrate 3 to 4 times a day for us to eventually get the values. If the value didn't match whatever you were trying to use in calibration, and what the CGM was recording was too different, it would send off alarms. This was, of course, all blinded. It would create havoc for some patients who were using this. Middle of the night, the alarm would go off. So we've lived through those times when it was very, very early nascent days. And as I say here, it did have its problem with the accuracy and the mismatch between the value used for calibration and what actual interstitial glucose value this system was picking up. But this is what we had. In fact, with this system, I had done my first study back then, which got published after several years because I was lethargic to get the data together and put it up. But this was the first one, and this was, I think, about 64 patients, where we all what I wanted to see was the trends in Indian patients with type 2 and what's happening. And we actually looked at different A1C classes, 6.5 and 7.9, and then the higher range of classes. So I think we had 4 different groups here, which we used to look at the profiles of glucose and C. And we found here that daily glycemic excursions in Indian type 2 patients became more evident with, of course, worsening duration of diabetes. Excursions in postprandial glucose values were statistically significant with even narrower differences in A1C, while excursions in the morning and nocturnal glucose values required wide differences between A1C. So these were our earlier findings based on the very, very initial CGM study, which even when I look back today, I think I feel proud that yes, this study done much earlier with that limited system gave us insight into the variability and the patterns we would see in Indian patients. Then came iPro2, a more refined product from Medtronic, which became our go-to CGM. This would record up to 6 days, would pick up almost 288 readings a day, would require calibration 2 to 3 times a day, and was far more accurate than the earlier CGM Gold system. It had very good software reports coming in. As we can see, the iPro2 started giving us a better insight into the picture, the fluctuations and what was happening. It started giving us the coefficient of variation and standard duration reports available to us, and also it gave us daily reports in this printed format. So in fact, it was the iPro2 which got most of us, involved into doing CGMs regularly for our patients, and sharing these reports, including the daily insights, would allow us to have a better conversation with our patients and help them, track their glucose values and learn more about the variability and how different lifestyle or medications would help us change that. There would be pros and cons of iPro2. We can dwell on that. We don't use this much now. But the cons, if I say, was really that no alerts in terms of high and low, lengthy data entry to generate the report on care link. So you would actually have to enter all those values that the patient has used for calibration. Sensor placement only on the abdomen. Not too many were comfortable with that. Charging required, and sometimes there would be skin reactions with the CGM sensor on the abdomen. This was the first large study which was supported by Medtronic, and as we can see, many of us were involved in this study, which purely used the iPro2 CGM system to advocate changes in lifestyle and therapeutics, and then see what was the impact on HbA1c and variability. And this study concluded that iPro2 provides healthcare practitioners with insights and opportunities for initiating changes to treatment regimens and to diet and exercise behavior, and provided patients with improved knowledge of the importance of therapy compliance. Even today, why we're doing so much of CGM, including the real-time CGM, is for the same reason that we want our patients to get more insight into their glycemic movement and try and adhere and comply with therapeutics and lifestyle, because they're able to see how this is impacting them. And if I remember correctly, in the iPro2 study, the HbA1c difference in the purely with the use of CGM was about 0.6 to 0.7% at the end of 2 to 3 months. Then came the Abbott system, Freestyle Libre Pro, and we felt extremely proud and glad that India was the first country that the Libre Pro was launched. In fact, we're trying to search for our picture when we launched it in our Mumbai conference in 2017. I think that on the stage we attached the first Libre Pro and did all the melodramatics around it for our patient. But it was great that this system came in small and discreet, working up to 14 days, and most importantly, not requiring calibration. I think that was a breakthrough as compared to all the earlier systems, and a longer life, and you could use the arm. So these were some of the major pros. Again, in that, you still did not have a alert, which now you have in the newer sensor generations, but you didn't have an alert in the earlier one. Sometimes the sensor would come off, the adhesive would not last, or patient would bang at the door and it would come out. And for all CGMs, we do know that there would be interfering substances like high dose of vitamin C, salicylic acid, and so on, which may cause interference in the interstitial fluid glucose. So if you compare between the Freestyle Libre Pro, which we still use a lot in our country as compared to the earlier iPro2, longer life, startup time was similar, no calibration required here. In Medtronic, you would require calibration 2 to 3 times a day. Frequency of readings, less frequent every 15 minutes in the Pro, every 5 minutes in the iPro2. A little better MAR for Libre Pro as compared to Medtronic iPro2. And then you look at the Freestyle Libre, which was the real-time CGM system, which came in India, and we are still stuck with that. So we are still stuck with the Libre 1. We don't have the 2 and 3 generation sensors as available in many parts of the world, but this is the best we have. And people would have to use their readers to scan and get the values. No official software was available for a long time, but that has also changed. And last year in October, we had the software coming in, and I'll briefly show that, because we want to dwell more into the software analytics and how to optimize that use in our next session in the weeks to come. So difference between the Pro and the Freestyle, well, the Freestyle Libre is for self-management of patients. This is for patient use themselves. They have to attach it and they have to keep scanning and seeing the data. The Libre Pro is where you want to see the glycemic movement, the blinded glucose values. For this, ideally, the patient has to come to the doctor's clinic. We attach the Pro and they come back after 7 days in an interim period, or 14 days for us to download the data and discuss the movement and profile. Now, in simple words, let's remember that for your patient where you want to see the glycemic movement and profile, somebody with pre-diabetes, somebody with diabetes starting treatment, somebody wanting to see the impact of different lifestyle changes, or where there is a mismatch between SMBG and HbA1c, somebody who doesn't require to use CGM continuously and you want to just see the pattern, Pro is your go-to CGM. For individuals who are experiencing fluctuations or on multiple daily insulins, who want to see the sugars on a continuous basis, it's Libre Freestyle. So the impact of Libre Freestyle is only for those 14 days where you wear it, and every 14 day would be different. Whereas the Pro, what you wear for 14 days will have some predictability over the next 2 to 3 months. So it's for those who don't require constant CGM. Now, these have been our efforts and papers, insights to the time and range on flash glucose monitoring, which was presented at the ATTD a couple of years back. We focused in our CGM studies largely on picking up a time below range. And I still feel one of the most important aspects of CGMs as they have evolved is not only to look at variability, but picking up unrecognized TBR or hypoglycemia. And that's a major strength. Of course, today, and this was all with the Pro. Today with the real-time CGMs, the larger strength is to see the direction that the glucose is moving in and prevent going into hypoglycemia. This was our paper which Purvi had steered, largely reporting the gender disparity that even today in our country, if you analyze the amount of CGMs used, there is a wide divide, and females in our country are not offered the use of technology, probably for financial reasons, that they don't give themselves preference or the families don't spend on them, and this should change. So LibreView was launched in October 23, which has made life easier. It has 3 aspects to it. The patient downloads the Libre Link app, which they are able to see on their smartphone. The same smartphone with NFC can be used for scanning this sensor and getting the data. You don't need that black reader anymore. They can transfer this information to their family members and caregivers with the Libre Link Up app. And as a doctor, they are able to connect this information to the software on your laptops or desktops with the LibreView. So your clinic will generate a code which you share with the patient. They enter that code and immediately the information gets transferred and shared with what you can see at the clinic. So this is the patient dashboard at our clinic, and multiple patients now getting enrolled. At the click of a button, I'm able to see how their sugars are moving, provided they are using the
Recording
freestyle
stopped.
CGM, right? The Dexcom ONE sensor. Well, let me actually just give insight into what we have ahead. We have the Dexcom ONE sensor, which we expect in India. This is a little toned down version of the Dexcom G7, but seems to be pretty accurate. Can be used up to 10 days. All of these are water resistant. Will sends glucose readings to your compatible smartphone, as we can see here, every 5 minutes. Probably has comparable MARD to the generation to Freestyle Libre 2 and 3 series, and is compatible with many other insulin pump systems, which would make life easier for patients opting not to use the one company's pump and the same company CGM, but have a compatible one between this and whether it's the Omnipod or the tandem insulin pumps. So in the interest of time, let me stop here, giving an overview of what we have moved to. What we don't have moving ahead and what the world has is the Freestyle Libre 2 system, which has more alerts coming up there, which is what is more important, and the Libre 3, which is truly a real-time CGM and not an intermittent scan CGM, which still the current CGMs which we have, we call them intermittent scan because you still require to scan either with the reader or the phone to get the data. When you move to the real-time CGM systems like the Libre 3 or the Dexcom G1, they won't require scanning. Even if the patient forgets to scan, the information will get transferred to the continuous basis. So this is what we await ahead. And as I said, we will dwell more into the nuances of the CGM reports, the AGP, the metrics for glycemic variability, and what is the clinical utility of all of this in our sessions ahead. So I end here and I stop sharing and hand it back to Mithun for the next 5 minutes time that we have for discussion. Thank you.
Thank you, Manoj. So I have a question to both of you. How we can get it more widely acceptable, the technology, or how we can arm twist companies to make it more affordable. There was some DIY insulin pump, we were, as Jyoti and Manoj will be aware, an Indian, student was trying to develop that at low cost. So how we can arm twist and how we can get this more affordable. The first thing that comes with CGM, as Manoj, is people say, "Arey, this is very expensive." So the mind gets shut after that. So how can you encourage people, or what is the answer we can do to overcome that?
Well, so thanks, and Jyoti will agree and add to this. So it's essentially creating awareness about the clinical utilities and how this is so useful. So many of us using it today would find it difficult to actually manage patients without seeing this information. Like in the past, you've managed sugars only by looking at one random sugar. There was no HbA1c. We imagine today that how could you do that? And then we moved to an area that we wanted SMBG as well as HbA1c to be more accurate in helping our patients. Similarly, today in many patients, you look at type 1s, you look at many other patients on basal bolus, without having enough data, you know that you're trying to hit in the dark. So creating awareness with case examples is how you're enlightening people. Yes, affordability in our country always is an issue, but everywhere, including rural areas, there are enough people who can prioritize their health and who can afford the use of technology. It's important today that the clinician is aware and has a conversation. If the patient cannot afford, it's fine. But let them know that this is available. If they can't afford it today and they need it tomorrow, they may prioritize the use of this. So I think through these sessions and essentially what we are doing at DTech is trying to train more and more physicians and younger physicians who are keen to adopt technology, making them more aware about the nuances and the clinical utility.
Thank you, Manoj. Jyoti, your view.
Yeah, I agree with Dr. Manoj. So, Mithun, I am reminded of procuring the glucometer, first glucometer, and that was for my mother. And in the late 1980s, and I managed to have the reflectance glucometer from AIMS, and that was costing around 8,000 rupees. And it requires almost 10 minutes to measure the glucose. And it is fairly accurate as well. And it is still with me. So from there, if you look at the rapid advancements in technology, now the glucometers, as you said, when you compare with the CGM, it is far less expensive nowadays. And if you look at the lifespan of a person, with or without diabetes globally, 200 years ago, the average lifespan used to be around 20-25 years. And in 1920s, the average lifespan used to be around 35 years. And now it is above 70-75 years. So if you are a responsible doctor aiming for a better control of diabetes and minimizing the glucose variability, and with diabetes living for another 30, 40, or 50 years, and with an option to reduce or eliminate the complications, you have the embrace technologies. And the cost should not be a burden when we doctors are successful in communicating with our patients on the benefit of a technology. So Manoj spoke about CGM, and I always used to tell my patients that after the discovery of insulin, and that was more than 100 years ago, the second best discovery in diabetes is absolutely no doubt, they are the reliable CGMs. And if the patients are aware of that, they will definitely procure it. But over time, our Diabetes Technology Trust of India, we as an organization, along with the doctor community and with the members, we will also be able to bring down the cost so that the common people, the common men will also be able to afford an automated insulin delivery. And everybody with type 1 and type 2, that should be the future and the dream, will be using a continuous glucose sensor. Mithun, you are muted.
Mithun, this is like the intermittent scanning. You know, you forget to
know
scan.
it's getting intermittent scanning.
You should have an automated reminder.
Our dear friend Amit is there as well with us. Amit, are you there? So I think he's gone off. So are there any questions from the audience from MedSynapse? If not, I would be very glad to pass on to our host, Nigar.
Amit is there. Dr. Amit is
there.
Yeah.
Yes, sir, I'm there.
Amit, your take on how we can excite people. That's why we are doing DTech, to get people more and more well trained. But technology has changed. In fact, as Manoj was saying, I don't know before CGM how I was treating diabetes. So it has completely changed. Now fasting PP is very difficult to. I don't know if I'm doing the right thing if some patient doesn't agree for CGMS. So it's so much wide variety is there. So Amit, your 2 cents on that, and then we'll pass on to Nigar.
Dr. Mithun, I would just like to say that technology is changing so rapidly and so fast. And every day, so many applications are coming, whether it is AI or whether it is machine learning, that I feel that I need to learn and relearn a lot of things, which I already knew. So I don't think there is any choice for anyone that they cannot learn about technology. And if there is any option which is available in our country, I think any meeting which is having sessions for technology and exclusively technology is DTech. So by any means, whether we like it or not, technology is going to slowly creep into our medical practice like anything.
Yeah, I think it's sooner we embrace it, it is better. Otherwise, we'll become extinct in practicing and not giving the best to our patients. I think on that note, I would be very happy to thank both my speakers for a wonderful, lucid, from the heart, their experience on both the topics. And I pass on the baton back to the organizer. Nigar, over back to you.
Dear doctors, I would like to thank each and one of you for this very enlightening and very insightful session. And we have some questions from our audience. There's one question for Dr. Jothydev. The question is, how did the evolution of insulin injection devices contribute to the ease and precision of insulin delivery?
I think the answer is there in the question itself, Dr. Nigar. And when you compare with the ordinary glass syringes with the insulin pen needles and the newer smart insulin pens, the delivery devices have improved a lot. The insulin injections are now virtually painless. So we tell our patients that insulin injections are not with needles, but with filaments. And even with a 3-year-old or a 4-year-old can inject herself or himself without no pain at all. And that is something which has promoted the widespread adoption of insulin injections and also GLP-1 injections. And of late, I would say that the introduction of a 780G or Omnipod 5 along with Dexcom G6 as a automated insulin delivery device has resulted in a successful TAR more than 80 to 85%. So in terms of convenience, in terms of painless injections, in terms of adaptability, in terms of avoidance of hypo and hyperglycemia, all of them translating to much better outcomes, preventing the vascular complications of diabetes. So I would say that the delivery devices of insulin are equally important to insulin itself. So when we are having newer insulins, the delivery devices are also equally important. Thank you. Thank you, Dr. Nigar.
Thank you so much for making that clear, Dr. Jothydev. Now, we have a question for Dr. Manoj. The question is, what best a doctor can do to make his diabetic patients at ease with these CGMs and insulin pumps? And also, what benefits arise from the integration of insulin pumps with continuous glucose monitoring systems in the management of diabetes?
Right, it's a great question there, Nigar. And the response to that is that whenever we use and adopt technology or put our patients onto the same, we as clinicians should remember that the right choice of patient is extremely important. Essentially, no aspect of treatment should involve increasing the patient's distress. If you have an individual who's going to get completely overwhelmed with the use of technology, devices, then that's not the best candidate. So as a doctor, you need to evaluate that for who you're going to be advising which technology. At the same time, sufficient training when you start using either a CGM device or an insulin pump, spending enough time for sufficient training to know what to expect, what are the limitations, how to react or not to react to particular readings is important so that the patient continues to maintain belief in the system. And as I said earlier, doesn't get overwhelmed or doesn't overreact to the limitations of the system. To the second part of your question, the benefits of integrating CGMs and insulin delivery devices like pumps, well, that's what is making the breakthrough today, especially in patients with type 1 diabetes, with also huge potential for pregnancy in diabetes and type 2 patients on multiple insulin shots. So the 780G systems, which is from the same company, an integrated system between CGM and pumps, and today the possibility of integrating many other devices like Dr. Jyoti said, which is your Optimed and the Dexcom systems, or the DIY where patients themselves are using these systems and using the software hacks to ensure that the algorithms can maintain the connect between the CGM, which is going to continuously monitor glucose, transfer the data to the insulin pumps, which can automatically deliver insulin and self-regulate the rate at which insulin has been given to ensure a tight range in control, avoiding the fluctuations. So that's the future. Well, the future is already here, but we will see improvements and more fine-tuning of these technological devices helping our patients with diabetes ahead.
Thank you so much, Dr. Manoj, for making it very clear to our audience. Truly appreciate it. Now, as we conclude this insightful session, we extend our heartfelt thanks to all our distinguished speakers today, Dr. Jothydev Kasavadev, Dr. Manoj Chawla, and Dr. Mithun Bhartia, for sharing their valuable insights with us this evening. Thank you once again for being a part of this enlightening event, and we look forward to welcoming you to future sessions. And to our esteemed audience, we also want to express our gratitude for joining us today. And before I say goodbye, I encourage each of you, especially if you're healthcare professionals, to explore the enriching opportunities available on our MedSynapse platform. It's a unique space where you can engage in meaningful discussions, connect with esteemed medical professionals, and contribute to the continuous progress of healthcare.
Thank you. On that note, Nigar, I would also say that I would like to invite all the audience for our DTech meeting in Kochi, including yourself, so that you can get a, you are physically there and you can see how we can then partner with MedSynapse to actually partner technology advancements in our region.
Definitely, Doctor. I would love to be part of it. Looking forward to it.
Thank you. Bye-bye.
Thank you so much.
Thank you very much. Thank you very much. Thank you, Dr. Nika.
Thank you.
Bye-bye, Manoj. Mithun,
Bye.
bye. Thank you.
Thank you. Goodbye.
Bye. Good night, everyone. Bye.
Good night.